Thank you, Assemblymember. Next, we'll go to Assemblymember Wood. Dr. Wood for file item number 17, AB 941.
Thank you, Chair and members. Assembly Bill 941. The majority of California tribal health clinics are located in rural areas of the state, such as my expansive district, where access to health care services is challenging and there are many unmet needs. My sprawling district represents more Native American tribes than any other in the state. Tribal clinics cannot always establish new clinics on Indian land, as many tribal members live off the reservation or rancheria. This requires opening new tribal clinics on non-Indian land in order to provide adequate access to care for patients of all backgrounds. The licensing process to open a tribal clinic on non-Indian land is duplicative, time-consuming, and costly, especially with regard to the license from the Department of Public Health. Tribal health facilities are licensed under the federal government and Indian Health Service licensing process, and this process is very comprehensive. The staff time and resources used in a duplicative application with the state could be better spent on providing for additional patient health care needs. I will note also that many of these tribal clinics also provide services to the general public and are often the only health care providers in the area. AB 941 exempts tribal health care clinics located off tribal lands from the Department of Health state facility license. This bill only addresses the exemption of clinics from the Department of Public Health licensing while still complying with other state laws such as Cal OSHA, California Fire Code, California Building Safeties Code, Seismic Safety Standards, Patients and Employee Safety, California drug laws, and many others. Worker safety and protections are completely covered through compliance with existing state laws. I know that there are concerns regarding this change, and I'd like to oppose a couple that I have heard. One concern is regarding licensed healthcare practitioners employed by tribal healthcare programs. I am sympathetic to the concerns. However, after preliminary research, is my understanding, under the Affordable Care Act, a healthcare practitioner employed by a tribal health program is exempt from California licensure if the practitioner is licensed in another state. Just 2 years ago, our legislature passed a bill that was signed by the governor to conform to the ACA, allowing this exemption. Additionally, it appears the exemption applies to all healthcare practitioners regardless of location, so long as they are employed by a tribal health program. I would prefer to see that all practitioners in our state be licensed by California. However, I do not want to be in conflict with federal law via the Affordable Care Act, and I also want to respect the sovereignty of the tribes. That said, I'm happy to pursue a legislative council opinion on the interpretation of ACA and the implications for licensure of health professionals working in tribal clinics. While I seek this clarification, I would ask that you allow my bill to move forward. Here to testify in support are Mark LeBeau, the Executive Director of the California Rural Health Board, and Kimberly Chen, a Policy Advocate at the California Pan-Ethnic Health Network. Thank you.
Good afternoon, Honorable Chair Bonta, committee members. Thank you for inviting me to testify about the importance of Assemblymember Wood's legislation, AB 941. On behalf of the California Rural Indian Health Board, a nonprofit and federal tribal organization established in 1969 and representing 30 federal tribal governments and their tribal clinics, I respectfully request the committee support AB 941. The California Primary Care Association, which represents over 1,000 clinics throughout the state, the Latino Coalition for a Healthy California, the California Pan-Ethnic Health Network, and multiple tribal governments and tribal clinics across the state also respectfully request the committee's support of the bill. AB 941 would create a much-needed single standard for clinic licensure for federal tribal clinics in California. The federal government requires tribal clinics to provide care only within federal service areas. These areas are primarily in rural, mountainous, and frontier regions in the state. In addition, the federal government provides tribal clinics about 50% of the funding they need to operate. The tribal clinics primarily provide services to low-income individuals and families within their service areas, many through administering Medi-Cal services. If a tribal clinic is located on federal Indian land, it is exempt from state licensure because the tribal clinic adheres to all federal facility standards and requirements, including providing quality services and patient protection and remedy measures. In addition, the federal standards are essentially the same as the state standards. If a tribal clinic is not located on Indian land, it may still be exempt from state licensure by having a working partnership with an institution of higher learning. If a tribal clinic is not on Indian land or does not have an affiliation with a university, it must be licensed as a primary care clinic. The multiple tribal clinic licensing standards create undue administrative challenges for tribal clinics in their mission of providing federal health services. There are currently more than 15 state licensing exemptions for various types of healthcare clinics in California, including federal, county, and other government health facilities. Passage of AB 914 will eliminate the duplicative state clinic licensing standards for tribal clinics because they already have to adhere to many multiple regulations, state requirements, and federal requirements as well. Passage of AB 941 will not result in tribal clinics being placed in areas outside of their designated areas. It will greatly assist the tribal clinics in their critically important role of providing care. In light of these facts, I again respectfully request the committee support AB 941. Thank you.
Witnesses in support.
Kimberly Chen with the California Pan-Ethnic Health Network, pleased to support AB 941. This bill will help ensure that tribal communities, especially those in rural areas, have access to health care. And we know that Native American populations face tremendous health disparities, higher rates of high blood pressure, diagnosis of asthma and diabetes, and lack of access to care is one of those barriers that really contribute to health disparities. Tribal health programs play a crucial role in the healthcare infrastructure in tribal communities and provide quality, culturally appropriate care. And as Mr. LeBeau noted, they reach often very rural areas and hard-to-reach populations over expansive geographic areas. So it's important to ensure that these programs continue to serve in this role in tribal communities. For these reasons, CPEN is in support of AB 941 and urges your aye vote. Thank you.
Additional witnesses in support? Seeing none, witnesses.
Oh, sorry. Hi, my name is Christine Smith, and I just wanted to note a couple of other supporters of this bill. This bill is supported by Big Valley Band of Pomo Indians, the Blue Lake Rancheria, California Primary Care Association, Chapati Indian Health Program, Cloverdale Rancheria, Greenville Rancheria, Creek Tribe, Kashaya Band of Pomo Indians, Latino Coalition for a Healthy California, Northern Valley Indian Health, Pit River Tribe, Resahini Rancheria, Riverside San Bernardino County Indian Health System, Smith River Rancheria, Toyabe Indian Health Project, Tule River Indian Health Center, United Indian Health Services, Warner Mountain Indian Health Clinic, and the Yurok Tribe. Thank you.
Witnesses in opposition.
Chair and members, Michelle Cabrera with SEIU California. We do not have an oppose. We are simply registering some concerns, questions that we have about the bill. We've appreciated the author and sponsor's willingness to share with us and have dialogue, and we look forward to continuing that. SEIU represents the nurses who perform the health facilities licensure and certification, and currently they're just trying to do a crosswalk of the federal and state requirements that would apply. And part of the reason is this would not be a closed system. It would be open to all Californians. And so if it were something like the VA where it was a closed system, we wouldn't have any problems whatsoever. So we're doing our due diligence. Again, look forward to continuing to work with the author and appreciate the opportunity to provide input.
Sarah Flox, California Labor Federation, also not here in opposition, just raising concerns. We met with the author early on, and he was great about kind of giving us more information about what it would mean to have off-reservation tribal clinics operating without the licensure. We look forward to seeing the Ledge Council opinion and very much appreciate all the work that the author's office has done. So we would be happy to see this bill move forward as we continue to work with his office. Thank you.
Mr. Chair, Member Stephanie Roberson, on behalf of the California Nurses Association, on paper we are in opposition. I want to first thank the committee work that's been done on this issue, the author and his staff for being responsive to all of our questions and concerns. That has definitely been done. Again, just like my colleagues over here to my left, we're just doing our due diligence to really understand, the breadth of the complexities between state and federal laws. And we did ask to see a Ledge Council opinion. Happy to hear that the author is willing to take a look at that. Upon review, we'd be happy to remove our opposition, but for us, it has to do with that, out-of-state licensure piece. If, in fact, council has opined on that issue that clinics off tribal land can do that, then we'll be happy to move forward. And we also, are here to respect sovereign lands as well. We just want to do the best we can to make sure we have all the pieces put together. So, again, thank you for the work and want to move forward and work with you. Thank you.
Thank you. Thank you. Seeing no additional witnesses in opposition, any questions from committee members? We have a motion. We have a second. Seeing no questions from committee members, the motion is due pass to appropriations. Dr. Wood, would you like to close?
Just respectfully ask for your aye vote.
Thank you, Dr. Wood. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, aye. Bonilla? Burke? Chavez? Chu? Chu, aye. Gomez? Gonzalez? Gonzalez, aye. Hernandez? Lackey? Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas? Rodriguez? Rodriguez, aye. Santiago? Steinnorth? Thurman? Waldron? Wood?
Aye.
Wood, aye.
Your count is 8-0. We'll leave it on call. Thank you, Dr. Wood. Next, we'll go to Assemblymember DeBobney. You have two bills up, Mr. DeBobney. File item number 19, AB 1086, and file number 27, AB 1319. Feel free to proceed with whichever bill you would like to proceed with first. 1319? We'll start with AB 1319, file item number 27.
Tough one. Mr. Chair, Mr. Vice Chair, members, AB 1319 will help seniors in board and care facilities provide for their basic needs. This bill raises a personal incidental needs exemption from $20 to $50 for medically needy only seniors, otherwise known as MNO seniors, who are residing in Medi-Cal nursing home or community care facilities. Medically needy only is a Medi-Cal program that provides the option to extend Medi-Cal eligibility to individuals with high medical expenses whose income exceeds the federal poverty line, which was $15,856 in 2013. Under the current amount, that is $20, is hardly enough to cover the over-the-counter drugs, phone services, clothing, and other personal items such as hearing aid batteries and denture repairs that seniors need to live a healthy and active life. This bill came to light from the Los Angeles Jewish Home for the Aging and their effort to help residents maintain independence and dignity with monthly expenses in their board and care facilities. The amount has not been raised since 1970, over 40 years ago, and therefore raising the monthly amount will result in $360 per year, a modest increase that will help the quality of life for more than 12,000 financially needy seniors in our community. I would also be happy to address a few concerns of the bill in my closing statement, but with that, I'd be happy to take questions from any of my colleagues.
Thank you, Mr. DeBobney. Witnesses in support.
Nicole Wertelman on behalf of the Ventura County Board of Supervisors in support. We're appreciative of the introduction of the measure, and it will help improve the quality of life for some people who really need the help.
Other witnesses in support? Seeing none. Witnesses in opposition? Seeing none. Questions or comments from the committee? Seeing none, do we have a motion? Move the bill. We have a motion. I'll second it. No worries. Mr. Dubomne, you may close.
I'd just like to say that while this seems like a small and modest increase from $20 to $50 for a small group within our state, for these 12,000 seniors that live in care facilities, that extra money will help pay for not just items such as toothpaste, denture cream, being able to pay their phone bill to call loved ones, personal items such as clothing or Q-tips, but it also provides a level of dignity that they can continue to have an active style of life that pays them the respect that they deserve. I hope that this committee will consider this bill as a benefit to not only members in my community, but members of our senior community throughout the state. I respectfully ask your aye vote.
Okay, we have a motion and a second do pass to approps. I'd ask the clerk to please call the roll.
Bonta? Mainshine?
Aye.
Mainshine, aye. Bonilla? Burke? Chavez? Chu? Gomez? Gonzalez? Gonzalez, aye. Hernandez? Lackey? Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas? Rodriguez? Santiago? Steinnorth? Thurman? Waldron? Wood? Wood, aye. And 5.
You have 5 votes. Your item is on call. Mr. Dubomne, you may proceed with item 1086, or AB 1086, item 19.
Mr. Vice Chair, colleagues, AB 1086 will allow patients to stop serving as a middleman between doctors and insurance companies by requiring insurance companies to accept assignment of benefits, contracts, and issue payments directly to doctors. A preferred provider organization, otherwise known as a PPO, is a healthcare product that, among other things, allows free choice of providers. Health plans offer this product to consumers, promoting the freedom to choose to seek care from a provider who is not part of the PPO network. Consumers pay a premium for PPO products precisely because they offer consumer flexibility to choose the benefits and receive the care from a provider outside the network. The assignment of benefits refers to an arrangement where a patient with a PPO plan requests that his or her health benefit payments be made directly to a designated person or facility, such as a physician or hospital. Currently, these health plans will only send the payment directly to the patient. The impact of this policy has been to strain provider-patient relationships, divert healthcare dollars outside the system when patients mistakenly or intentionally misappropriate those funds for personal use, place healthcare consumers in an untenable financial situation, and put patients at risk for initial higher out-of-pocket expenses. For me, the real heart of this bill is trying to address the fundamentally difficult position that patients are placed in when trying to find life-savings care. When I will talk to my district at town halls or personal meetings with constituents at neighborhood coffees, I am often told about these cases that come up. These are patients that enjoy having a PPO, but simply put, they don't want to be put in the middle anymore. I'm pleased that we have been able to add a variety of protections that are not in current law, including a cost estimate and additional disclosure regarding the cost benefit of using an out-of-network provider. I would like to thank the chair and the committee for their work on the bill and accept amendments suggested in committee analysis, which are on page 7 and 8. With me today, I have representatives from CMA. They'll be testifying in support of this bill.
Thank you, Mr. Vice Chair. Janus Norman on behalf of the California Medical Association, representing over 40,000 physicians in our good state. This bill is really simple. I know it has been heavily lobbied in the midst of lots of confusion, so I would just like to take a step back and quickly explain what this bill is about. Under a PPO product, a patient is given the option, and is paid a higher premium actually, for the option of choosing an out-of-network doctor. In choosing an out-of-network doctor, they recognize that the benefits that they would receive or the cost sharing that they would receive from the health plan will be less, but they recognize that the plan will pay some portion of the bill that they would receive from the physician. Under existing law, PPO products that are regulated by the Department of Insurance already have to honor an assignment of benefits. Again, under existing law, PPO products regulated by the Department of Insurance already have to honor an assignment of benefits. An assignment of benefit, and one clarifying point, an assignment of benefit is not at the sole decision of the physician. It is also at the sole decision of the patient. The patient is asking the plan that they pay into on a monthly basis to, instead of providing them with a check that they don't really recognize what it's used for because literally the check just comes with their name on it and a dollar amount, they're asking for that check to be sent to the service provider that actually provided the medical care. Why is that important? It's important because the patient is at a higher risk of paying the total share of the bill. So for example, if you went and saw a doctor and the bill essentially, and I have to use really simple math for myself, and the bill came out at $100 and you went in network. If you went in network, they typically cover, the vast majority of that bill related to co-pays and deductibles and things of that nature. If you went out of network, yes ma'am, if you went out of network, you're responsible for a higher level of that cost. You are responsible for that cost. The assignment of benefit, if the health plan was only going to pay you $40, what we're discussing in this bill is not whether or not the health plan has to give you more than $40 or less than $40. The health plan is only going to give you $40. The question we're asking in this bill is, if the patient says, send that $40 to my physician, that's where the patient wants the money to go. And so the question that we ask, because only 2 plans don't recognize and honor the patient's choice, and that is Blue Shield and Blue Cross. That's the only 2 plans that do not honor this. They're under existing law, again, the vast majority of products, not lives, products regulated by the Department of Insurance are already providing an assignment of benefits, and they include none of the protections that are included in this bill. This bill is a good bill for consumers, this bill is a good bill for doctors, and quite frankly, it's fair to the plans because it's not asking them to pay more or to pay less. It's asking them to honor the wishes of the patients that pay their premiums every month. Thank you.
Mr. Chairman, members of the committee, Louis Brown on behalf of CalNet and the California Consortium of Addiction Programs and Professionals. This is an extremely important bill for the clients of the members we represent. The clients we represent are people suffering from substance abuse disorder. You can imagine in the early stages of substance abuse disorder what can happen if a consumer, a client, receives a large check from their insurance provider with no explanation attached to that check. We've seen in these instances where we prefer to go through this assignment of benefits that this check arriving can actually be the trigger that sends someone back into or out of recovery. It's extremely dangerous to clients. This is, from our perspective, a consumer health issue and one that would really help our consumers, our clients throughout the state of California. So the reason we ask for an aye vote today. Thank you.
Additional witnesses in support? Seeing none, witnesses in opposition?
Mr. Chair and members, with the indulgence of the committee, Health Access would like to be in an in-between position on this. We want to acknowledge the very substantial work that the author and the sponsor have undertaken and a substantially revised bill that is before you from the measure that was originally introduced, and acknowledge the numerous additional consumer protections that have been included. We, however, remain opposed. The last set of amendments added same-day appointments Our concern with this bill is to make sure that a consumer who engages in assignment of benefits does so knowingly and voluntarily. And for that reason, we were very pleased with the amendments that excluded emergency and urgent care and required 24 hours written consent. We had sought some additional protections for same-day appointments. We're unable to reach agreement with those prior to today. We would look forward to working with the author and the sponsors if the bill moves forward. Thank you.
Mr. Chair, members, Mark Weideman on behalf of Blue Shield of California, not-for-profit health plan with about 3.5 million members in California. Blue Shield is opposed to this bill, and I want to talk to you a little bit about what this bill does. All right, this bill is about a sliver of physicians, specialty physicians in the medical community who have chosen, purposefully and intentionally chosen, not to contract with health plans. It's not about the bulk of CMA's membership. All right, CMA testified they have 40,000 members. Well, Blue Shield has 65,000 physicians in its network alone. The vast majority of doctors contract with health plans. And let me tell you what that means for consumers. What a health plan does is not that different than what a labor union does. We take people, individuals who have no bargaining power in their own right. We take them, we collect them together, and we go in and we negotiate on their behalf. When we go negotiate with a physician, or a physician group, here's what we do. We negotiate for affordable rates for our members. We negotiate for quality in the physicians, so they must meet medical board standards, they must meet certain quality certifications, and we negotiate for protection of our members, which specifically means that doctor must agree that they are accepting payment from Blue Shield as payment in full for their services, that they will not turn around and balance bill our members. So they get a payment from Blue Shield and they say, okay, we're good with that. We contractually agree that's all we will accept for payment, and we will not go after your member for additional payment. The doctors we are talking about with this bill have decided not to contract with the health plan. They have said, we don't like your rates, they're too low, or we don't like your quality scores, they're too high, or we do not want to give up the right to balance bill patients for our rack rates. Those same doctors are now coming to you, the legislature. They're putting their trade association, I believe, in a very awkward position by asking for this bill year after year. This is the third time I've been opposed to this bill on behalf of Blue Shield, and it's died every time. They're coming to you as the legislature and saying, legislature, give us a statutory right to get paid by this health plan, even though me, as the doctor, I don't want to agree to that health plan's contract. Even though me as a doctor, I don't want to agree to their rates that they're negotiating with other doctors, I don't want to agree to their quality scores, and I don't want to agree to not be able to balance bill my patients. I want to do all those things, and I want you, the legislature, to statutorily require that health plan to pay me anyway. That's not right. If they really want to get paid directly by the plan, they have an avenue to do it. 65,000 other doctors have done it with Blue Shield of California. They've agreed to rates with us, they've agreed to quality standards with us, and they've agreed not to balance bill our members. They've agreed to accept Blue Shield's payment as payment in full. Now, if you approve this bill, if this bill were to get enacted, let me tell you what that means for the market. That means there is less of an incentive for doctors to negotiate contracts with health plans. Because if the legislature is saying, you're going to get paid anyway directly by that health plan because we're going to pass this bill, why would you enter into a contract with a health plan? You can charge the rack rate for your services. You can balance bill the patient for whatever you don't get from the health plan. Right? You can do all these things, not have to meet the health plan's quality scores, and the legislature is still going to guarantee you the right to get paid by that health plan. That's not right, and it's not the right thing for healthcare in California. We need to have ubiquitous networks. This is about Covered California. It's about Medi-Cal. It's about CalPERS. Those are the types of entities we serve. If we want to keep those networks broad and ubiquitous, we need to make sure that there are incentives for physicians to contract with health plans. And getting paid directly by a health plan is a major incentive. Thank you.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. I would like to echo many of the points that my colleague Mr. Weideman made. I think that our main issue is we believe that this exacerbates an already current problem that we have with getting anesthesiologists, radiologists, specialists, people who have captive audiences, people who serve rural and underserved areas to be willing to contract with us. We think that ease of payment is certainly a priority issue for physicians and a reason why, and a tool that we utilize to try and encourage doctors to contract with us. We think that patients are ultimately protected. The broader, the more expanded our networks are, the more protections against balance billing, the quality controls that exist when you are in contract certainly do provide additional protections to consumers. There was a bill last week that the chair authored, AB 533, that talked about surprise billing. That's exactly what many people experience. And part of that is because with the captive audience, individuals really do struggle with getting those individuals to contract with us. We think that this bill erodes our ability to get people to contract and in-network. We think that patients are all better off. The networks are better off. The healthcare product is better off with more doctors and physicians available to all individuals. So for those reasons, we remain opposed to the bill.
Thank you. Additional witnesses in opposition?
Yeah. Nick Luizos, California Association of Health Plans, in opposition.
Allison Barnett with Anthem Blue Cross, also opposed.
Thank you. Thank you. See no other witnesses in opposition. Committee questions. Assemblymember Gonzalez.
I have to say, from the empty seats up here, I think I'd echo the frustration I feel on this committee this year in particular by all sides. It's as if everybody wants to point to each other within the healthcare community about rising cost, about what's going wrong, and it's frustrating. I mean, we saw it last week and probably we'll see a bill again, and it's very hard to choose sides in a debate that appears where everybody is not a peer actor, obviously. So first of all, I'm frustrated, and I think I've expressed that to both sides on this debate. Frustrated because you can come in and explain your side, and it sounds perfectly reasonable, and yet it's very hard to make a choice here. So I'm going to approach this decision the way I have tried to approach every decision in health. I care about my community. We are sorely lacking for doctors, for providers. We don't probably have a whole lot of people who can afford a PPO, to be quite honest. So I want to know what this bill would do on either side. I'd ask either the opponents or the supporters to increase access to health care in poor communities like mine, working class communities. How will this provide more doctors or more access to doctors for my district?
Through the chair. I think that's a great question. And I think, simply put, it does increase access, and here's why. One of the major frustrations that physicians are having with individuals with PPO products that are going outside of their in-network. So partly in response to some of the things that the opposition said, the thing they're failing to acknowledge is a couple things. First, people are paying for the ability to go out of network. So they want to access that ability. So it's not an issue of the in-network service. They're paying to go out of network. Two, this is not balanced billing. I know they like to use that phrase a lot, but it's actually hogwash that they use it in this circumstance. And the reason that this bill and the author was so concerned about making sure that it's not balanced billing is so that the patient gets an estimate where they agree to what their cost exposure is in total. There is no going over that cost amount. So when the doctor provides that estimate and is looking at the patient and quite frankly is making the determination based on their years of experience whether or not they're going to get that bill paid, recognizing that a patient that has chosen to utilize their out-of-network benefit, that at least some of that bill will be paid because of direct payment from the health plan at the patient's choosing, will give them a greater level of comfort. How do I know that's true? The reason I know that's true is because Blue Shield last year, in looking at their products surrounding the healthcare exchange, began having their contracted doctors, but that weren't network doctors because they didn't have a contract for the health exchange product, began complaining to Blue Shield about the fact that they were not getting paid by the individuals who were getting a PPO product through the healthcare exchange and were getting subsidies. And so these individuals were taking the money, again, that's given to them with just their name on it, with no explanation of what this money is for, and they were taking those dollars and they were funding essential things. No one is trying to accuse anyone of doing anything improper. So in response to those providers, there's 65,000 providers that were complaining about the fact that they were having unbilled, services that were billed not being paid. Blue Shield actually implemented an assignment of benefits narrowly. So if you are one of the 65,000 that have a contract with Blue Shield, but you happen not to be in that narrow network that they provided to the healthcare exchange, and your constituent has the PPO product because they recognize that it's a narrow network in the healthcare exchange and they want to find a provider, they were having problems finding providers until Blue Shield implemented on their own an assignment of benefit. So yes, individuals in the exchange or lower income will benefit for this because at least the doctor knows, while they may not get the totality of their bill paid, again, under this bill, they've agreed to, they realize that at least the portion that the health plan is responsible for will be paid for. So yes, it will help in that instance. It will give you a greater comfort level.
Through the chair. Please. Thank you, Mr. Chair.
Please.
First of all, to briefly answer the statements made before, there is no uncontracted physician that we are honoring assignment of benefits to. All right, assignment of benefits has only been honored by Blue Shield doctors that have a Blue Shield contract, period. Otherwise, there'd be no need for this bill, right? This situation and the question you presented, Assemblywoman Gonzalez, is about what can we do as policymakers to encourage the broadest networks possible for your constituents and the constituents of, I'm sure, your colleagues. The fact that Blue Shield has the largest network in the state, and so does Blue Cross, and we both have an assignment of benefits policy, should give you pause. It's working. The fact that we do not pay a doctor directly unless they agree to our lower affordable rates, right, which means lower premiums to our members. We don't pay them directly unless they agree to our quality scores, and we don't pay them directly unless they agree not to balance bill our patients, right? Those are all very positive things for consumers, and there's 65,000 doctors in our network that had no problem agreeing to those things. That's the kind of thing we need to encourage, is getting more doctors into networks, because what that means, if they're in networks, that means the care is more affordable, quality is being monitored, patients aren't being balance billed. So a bill like this does exactly the opposite. It encourages doctors to fall out of health plan networks. Because if you fall out of the health plan network under this bill, you still get paid directly by the health plan, which is one of the benefits of being a contracted doctor. That health plan, that Blue Shield check comes every month, right? And it arrives, you know exactly when you're going to get it, and it pays for your rent, it pays for your staff. It is a very important thing when you're running a business. So it's a very valuable thing to get paid directly by us. We know it's valuable, and we use that as part of our negotiating. We know they want that check, and they want it directly from us. If you take that right away from us to have that as a negotiation tool, doctors will have less of an incentive to join our network. And if they don't join our networks, they'll charge whatever they want to members, to patients in California, and they'll balance bill for the rest.
Additional questions from members?